All right, this is a big day for us. We're going to show you and try and design an Athens Protocol case, but that's not the highlight of the day. The highlight of the day is we have George Waring III here in Athens. He's visiting for a meeting. He was kind enough to stop by and see how we try and normalize keratoconous.
My pleasure.
Thank you, George. So this is a young lady. She's in her 30s. And she has, we're just discussing with George actually whether this is keratoconous or maybe pellucid or somewhere in between, because there's a claw-like appearance on her placido disc topographies. And the pentacam shows that it's probably keratoconous because we can see that the periphery of this cornea is thicker than the paracentral area that's ectatic. Her minimal thickness is 444 per pentacam, and I'm going to try first. Her refraction is minus 275, minus 3 at 70 degrees. Now, as we have advocated for many years, this refraction has to be taken under consideration with the way these patients refract, because this patient refracted monocularly probably tilts his head back a little bit, maybe squints. So this may not always be the way we correct the astigmatism. We favor the topographic manifestation of the astigmatism rather than what the patients choose, and we have proven right on that choice because, again, they have a multifocal cornea, and when they refract it monocularly, they may throw you off of what actually the astigmatism is, not in the refraction, but in their cornea. So we're going to first draw up let's do the oculizer first, the pentacams. So this is the Wavelight refractive suite. This is the X500 excimer, and we're seeing here the 5 pentacams that have come up. Because the keratoconic eyes are super prolate, we don't have to adjust Q value. We put Q value at 0 because that saves us some tissue. Obviously, in a routine myopic case, we will choose Q value of -0.5 to increase cornea asphericity, but this cornea, you didn't see it before, but her asphericity was almost -1. So we put the desired Q value to 0 to save tissue, and it's going to end up anyway over -0.5, whatever the case. Then, in order to try and see if these pentacams are similar, we're going to use this index of similarity down here, which basically gives us a deviation between these 5 scans. Sometimes we go by luck, or sometimes we erase each one at a time until this number drops. Sometimes we have to exclude 2 to see this number being in the single digits, so 1/100th of dioptric deviation between each pentacam and the other. This is not bad to begin with. This is 0.2 dioptric deviation, but I think Vasco has a good idea which one to exclude. And she brought us down to 0.09, which is a whole lot better. Let's try, just for exercise sake, to take out some other ones. We're taking one more out. Now we're going back to 0.19. Let's put that back in. Let's take one other one out. We're taking this one out, and now we're at 0. So these 3 pentacams have 0 dioptric deviation according to the excimer laser between them as far as the astigmatism that they represent.
And Vaso, why did you pick out number 2 before? Could you put it back up and show it to us?
Yeah.
That's a good question.
Why this one?
Yes.
Why did you take out number 2?
Because we can fix it. 44 and all of them are 41, 42, 42.
So-
It depends. Sometimes maybe it's higher, or some other times are lower.
So
It depends on
you're doing
the
that
difference of the
by the numbers, not by the picture.
Sometimes it depends on the picture, but they are very similar to each
Yeah,
other.
they look the same.
So you go by the degrees.
George brings up a very good point. We usually go by the axis of the steep or the flat axis. If one of the axes of these pictures is way off, we'll try to take that one out. Or, as Vasco mentioned, if the keratometry is much different in one of them, or if qualitatively one of the pictures looks a little bit funnier. So,
But in this case, the pictures all look the same,
right,
more or less,
right,
so you went by the numbers.
right.
Uh-huh.
So that was good. This is one of the rare occasions that we have 3 pentacams and their interdeviation is 0. So let's do that again. Yes. Alright, so now let's feed this into the device. We're going to ask it to...
Let me ask one more question.
Sure.
Would you ever consider just averaging the 5?
It will do so if you leave it as is, it will average the 5. That's what it will do. And
But you want to get rid of the outlier.
I don't have an elegant way to prove you why it might be better that way. It's mainly through experience, but it's definitely worth looking into. We have traditionally tried not to be left with just 1 or 2 pentacams, to have more than 2, and have a reasonably small deviation between them. But that's a considerable argument to have the average, because maybe the truth lies between the average of them. That's a good point.
But now do I understand you're going to take these 3 and average that?
Right.
Yes.
So we'll take the average of the 3,
So
which
you do both. Eliminate the outliers, average the remainder.
exactly. So we're going to go to the next step now, which basically will give us the proposed. Okay. We're going to zoom in to show you how the device goes to the next step. We're not going to put it, let's put the refraction in, minus 275 and minus 3 at 70 degrees. And this is the manifest refraction, so this is a subjective refraction. And again, as we mentioned, monocular subjective refraction. So the device automatically puts in the pachymetry measurements that it feeds in through the pentacam. We're going to go to the next step. And good. So now this is the, we're going to make some adjustments, because obviously the laser protocol is mainly based on LASIK. So we're going to take out the flap. There'll be no flap here. We'll zero the flap. We will try and trim down the optical zone. We'll sacrifice the optical zone to increase the amount of normalization we can achieve. So we're going to go to 5.5. See how that 5.5 serves us. And then we're going to zero the refraction here. We're going to try and see what the laser will attempt to do just to make this cornea more spherical. So this is what the laser is trying to do, and this is what the pentacam shows us. In respect to where the thinnest part of the cornea is, we would agree that at least qualitatively it's trying to do the right job. It's going to laser over the peak of the cone, and then we're going to see a large hyperopic treatment away from the cone in an attempt to re-steepen the flat area that is caused by the cone steepening. So the interesting thing here, this is the most puzzling thing, and we've learned this, or we think we've learned this by experience, is that the topographic cylinder is at 37 degrees, where the refractive cylinder is at 70 degrees. And in these cases, we always respect, which is the only occasion, the topographic cylinder. We will not pay attention to the refractive cylinder, but the topographic cylinder. So we're going to adjust our treatment axis to 37 degrees. And now we see that we have some room to work. We have 447 microns left in the central cornea, even with this adjustment. And we're going to try and tickle a little bit the myopia and the astigmatism to a degree that will not thin this cornea under 400 microns. So let's do this. We have to keep in mind that since this cone is not central, it's quite oblique. This ablation will steepen the paracentral cornea and might induce myopia. So in this case, since a lot of the astigmatism has been taken care of, I'm going to spend more energy on treating myopia and less cylinder. So we're going to do maybe 1.5 diopters of myopia, and then we're still at 433, and then maybe do a diopter cylinder. Maybe do myopia to 2 diopters. The cylinder is sitting as tissue there. So go to 2 diopters, 1 cylinder, we're still at 424. Let's go to 2.5 myopia. So this is basically what we would do in a traditional case. And just to see the comparison now on tissue reserve, if we do the same case with a optical zone of 6 millimeters, instead of leaving 420 microns residual in the center, we lose about 50 microns more. We go to 4 or 6. If we had chosen to go to 5 millimeters, which is a tiny optical zone, we would have 12, 13 microns more in tissue reserve. Since we do have some tissue reserve in this case, remember we're gonna cross-link this case after mineralization. We would probably go to 5.5. This is probably the best medium between normalizing the cornea significantly and correcting some of the myopia and some of the astigmatism. Keep in mind that although the refractive astigmatism is 3 diopters, the topometric astigmatism is 4. So maybe then see what half of diopter more astigmatism will cost us tissue. It doesn't cost the patient anymore. So it actually increases the tissue reserve. So we're going to move more towards that direction. And this is kind of a trial and error way to cook the numbers and normalize the cornea as much as we can, preserve as much cornea as possible, and correct as much as refractive error as possible.
John, why do you use 400 residual tissue as your number?
It's arbitrary. I mean, we
250 is what's often cited as the residual safe stromal thickness.
Right. The initial cross-linking research mentioned that 400 of minimal cornea thickness left behind is a safe enough threshold to cross-link the cornea.
So this doesn't have to do with corneal stability, it has to do with ultraviolet radiation.
Right. We have had, though, and we've reported on this, we have had to treat corneas that were as thin as 350 to begin with. And on those corneas, we trimmed them down to maybe 330, as only other alternative being a penetrating graft. And we have done this in the past, we've reported this, and we got away with it. But we don't practice this routinely. We try, for instance, if there was a significant refractive error left behind with this patient, I would rather use a toric ICL or a lens-based procedure rather than use all of my armamentarium on the cornea. Because my drive in working on the cornea here is to normalize the cornea as much as possible. It's to increase best corrected vision acuity, not necessarily uncorrected vision acuity. We saw that climbing up a little bit of the astigmatism didn't cost us any tissue, so we're going to climb a little bit more until it starts to ring some bells on the tissue-wise. We just lost 3 microns for half a diopter astigmatism. I think we're going to probably stay here. This is a reasonable number. 2.5 diopters of myopia, 2 diopters of astigmatism. We expect about a diopter correction from the cross-linking alone. So we'll be ballpark within what this patient is. She's 275 minus 3. But one has to keep in mind that the PTK mode with this laser undertreats the center. So it induces a little bit of myopia. So theoretically, her refraction is a minus 325 minus 3 at whatever degrees. So this will be pretty much what we expect for this lady to bring her to metropia.
So the epithelium is having a refractive effect. And when you take that off with the PTK, that's affecting the refraction, even though you're not affecting the stroma at that time.
Like, not only that, this laser has a disadvantage, which for these cases, in my opinion, is an advantage. It has, within its PTK protocol, it uses the same firing algorithm with plain myopia, so it puts more shots in the periphery. So at the PTK, we'll see while we treat this patient, down around 50% through the treatment, PTK will be 6.5 millimeters in diameter, we'll see the epithelium starting to blacken in the periphery, which means we're at Bowman's membrane. 50% through the PTK. So that means the rest of the PTK at 6.5 millimeters diameter and we'll see the epithelial maps on this patient as well. We have them. It'll be going through Bowman's, where in the center, the cone will appear around 75% down the PTK. And the epithelium over the cone is around 38 to 40 microns thickness. So that tells us that the periphery, which is about 55 to 60 microns, gets more shots just because the laser uses the same algorithm with myopia for PTK, which is not the proper way to do this. And we know by experience, even treating a normal eye, if we just do PTK with this laser, will induce half the battle myopia.
Because you're thinning the periphery.
We're thinning a little bit the periphery. It does a mild hyperopic correction. And that's why we recommend to do a PTK scrape even on normal cross-linking cases where somebody does not want to do laser, because this PTK epi scrape will create a little furrow at Bowman's at the periphery of the PTK and will allow better riboflavin penetration. So even in cases where we had no tissue reserves to do any laser manipulation, we would still use the PTK mode with this laser instead of removing the field with alcohol, because it would create a refractive change in these cases.
If you did the alcohol.
If we did the PTK. If we do the PTK, it will create a refractive change. If we do the alcohol, not as much. So this is the, we'll save these. These are the pentacam-driven topo guided. So let's save these also. And then we'll do the same exact exercise with placido disc images. And then we'll compare the two. We'll try and see how the two compare. The only advantage that placido disc images give us with this machine is that since they come with a device that recognizes iris and limbal architecture, we can also cyclo-tort the ablation according to the cyclodeviation of the eye under the laser. So even if we do it pentacam driven, we're going to test this patient's cyclodeviation beforehand to make sure that it's not extreme. If it's extreme, we're going to go placido disc driven. So this is fully customizable. So again, we're doing the same thing. The pre-op Q value is at minus 0.6. So these are hyperprolate corneas. So we'll zero it as the desired. And now looking at these placido disc images, and again we have 5, they have a deviation between them of the same, 0.19 diopters. Vaso, which one should we pick? We'll have Dr. Waring pick which topography we'll throw out. Number 2 again, okay. And that's because, George?
Because the power is oh no, it's not an outlier. Excuse me, I'm reading that. Yeah, the power is 40. This is the mean power here.
This is the steep and flat meridian. So this is the flat and the steep meridian.
So this is less than the others.
Right.
And
the flat axis is also less than the others.
this is less than the others, so it's an outlier.
Right. And also, I forgot to mention before that on these images, the device itself senses which placido disc image had the most information, meaning the wider and the best quality. And it tells us that this one is probably the one that was the least accurate. Okay. So let's try what happens if we take that out. It improves a little bit.
That's why I knew it, because the machine told me number 2.
Right. Let's try others now. Let's take one more out. So we're still staying at 0.13. 0.22 gets worse. 0.19. 0.13. So I think 0.22. So I think George's was the best choice. It gives us the best deviation. And again, this is typical for placido disc. There's more inter-exam deviation than pentacam, because even though these look very similar, the keratometries look very similar, the machine is sensing more variability than it does with the pentacams. And this is what we have found in the past, that pentacam driven with this device was more successful in normalizing the cornea than placido disc driven. And And this was against the traditional teaching that we had in the device. We were taught that placebo disc driven would have been better, but it seems like in keratonic eyes, pentacam is better. Okay, so let's move on to the next step. Everything else here is the same. The pachymetry measurements come in from the pentacam measurements, so the device has the ability to use them. Although we're not using pentacam topography maps here, we have the refraction ready from the previous design, and we'll again put flap at 0 because this is a PRK case. We'll put the optical zone to 5.5. We learned that tissue-wise in the previous case. And we're going to start zeroing the refraction. And again, here you remember the axis from the pentacam was very close to the topography axis. This is 33. I think the pentacam was 34. So they're almost identical. So we're going to respect the topography axis. And again, we're seeing the exact same image, which fits, although this is placido-derived, fits with the pentacam-derived image. And now this placido-derived from the placido image that we see here and addresses the cone in a similar way. So we're going to try the same numbers, minus 2.5, minus 2 at 33. And the residual here is exactly the same, 413.
And this represents then an average of the 4 placido topographies that we did.
It's
so
the average of the 4.
Taking out the outlier and then averaging the remainders.
The only advantage that we see now with the placido disc images is that this will be able to be also tracked according to the secular torsion of the eye. So this may have a potential advantage, and we're going to store this as well. And we're going to start the
This is
of
because
this.
you have iris registration.
Exactly. And
All
limbal,
the placido images.
iris and limbal architecture. And also the device has stored within it, although we're seeing a dilated image here, it has stored a dilated and myotic pupil. This placido disc device takes a picture with a pupil myotic and scotopic, or mesopic should I say. So when we match the pupil size to what the device has, it's also going to match the centroid shift. So we have centroid shift, cyclodeviation, and corneal irregularity theoretically treated at the same time.
And are you going to talk about centering later?
Yes, we'll do it at live in the case. We'll do the centroid shift. Okay? So now we can compare the two treatments and they're identical. They're essentially identical, which gives us a little bit of comfort when treating such irregular corneas. It's nice to see that both modalities give you a similar pattern. It gets tricky when they're different. And then
You don't know which is right.
Then you have to maybe test the patient even more. Then we involve more topographies. We work with the Cassini topography, which is a multicolor spot reflection topography, which is more accurate in the center compared to the placido disc. We involve pentacam, actually OCT definition of the thinnest part of the cornea. So we use the OCT plotting of where the thinnest part of the cornea is and see how that corresponds with the most elevated part on the pentacam and the steepest part on the placido. So if we have discrepancy, we'll put other tools in to try and figure out, or hopefully hope that we have figured out the more accurate position. Good. So we're ready. So let's have Dr. Waring design the next patient. You're on your own. This is a very interesting case because this case is not keratoconous. This is a cornea scar. So here we have to use placido disc because pentacam is kind of blind to cornea scars. So this is the pentacam. This is the placido. And here we might see differences. We're going to feed both, but this would be a good example where we would use placido disc versus pentacam because this is a patient who has a significant cornea scar that has developed this significant flattened under the center.
Well, and the index of refraction in the cornea scar is different than clear cornea, which is why the pentacam, in a sense, gets confused.
Right. So that's another reason why the pentacam would be off. All right, so let's bring up these data closer. So we can all appreciate this is a very regular cornea. Let's do the pentacam first. Okay, so this is another case. This is not keratoconous, although as you can see here, the cornea is thinner at this area, which is inferior. This is actually a cornea scar.
It's also flattered.
Exactly, and it's also flattered. So this is a cornea scar from a contact lens infection on this patient that has created a significant step in the center of the cornea, very flat, inferiorly very steep, superiorly, and we have imaged this by pentacam. You can see on the scientific image the hyper-reflectivity of the scar, and also the fact that the pentacam undermeasures the thickness of this cornea. And we also have placido disc derived images here showing the significant width, the real astigmatism. You can see it on the placido Myers, and now here as well. So we're going to try both modalities here as well.
And it's worth familiarizing ourselves with the placido image by itself, because a good clinician doesn't need color coding. You can look at this, look at the shape of these Myers and the steps between them, and you can create this picture in your mind by just looking at the placido. So even though we sometimes consider the placido image old-fashioned, it's old topography, we need to still learn how to look at this image and understand what's going on, because that's the real picture. The rest of this is just mathematically derived.
Very excellent point. And this, 20 years ago, we would probably attempt an astigmatic keratotomy here based purely on the placido disc image, and then titrate it according to what the image would be in sequential mapping.
Good. Here's a question, John. You notice here that the lid is covering this upper area, and yet we have readings from the upper area. How can that happen?
Well, it's extrapolating the numbers, but it's giving us dotted lines where the data are not directly raw data translated to topography. So we kind of have an idea which part of the cornea is imaged and which part is extrapolated based on the available data. So the available data is just this.
And that's a good example of where the color-coded interpolation can maybe lead you astray a little bit, because we don't really know what it's like underneath the eyelid here.
And that's an excellent point also as well in pentacams, because we see pentacam maps. Well, for us to send pentacam maps through the device, we always have the vertical scientific image to make sure there's no eyelid within that image, because the pentacam, as it stands for the device, cannot give you a warning sign of whether there was a poor exposure of the cornea during that image. So with the pentacam maps, for the pentacam maps to come through, we always want a vertical scientific image showing us where the lids are in relation to the limbs. So let's have Vaso shoot in the pentacams, and we'll have Dr. Waring do us the honor here. Now here, this is not a keratoconus cornea, so we might go Q value minus half. It's a very regular cornea, but we want to get some accuracy.
Explain to us, for basic understanding, what the Q value measures and why you would set it at 0.1.
Right, the Q value measures the asymmetry between the curvature in the center and the periphery. And human corneas are highly prolic, meaning they're flatter in the periphery than they are in the center, just to avoid chromatic aberration from the prismatic effect that the cornea would have on light, multicolor light going through our eye. So when we do myopic corrections, we usually flatten the center, which makes then, in response, the periphery steeper, and that increases the oblateness of the cornea, meaning decreases the asphericity. And we have the ability in this laser to try and normalize the asphericity. The asphericity is not going to end up -half, but we can at least tickle it, if I can use the term a little bit, to be the least oblate possible. But it's not that we get -half asphericities. And since we're talking about asphericity, everything we talk about asphericity is at the reference of 7mm diameter, because asphericity also depends on which diameter from the center of the cornea we define. And all the asphericities we talk about here are at the 7mm diameter. So we have our asphericity in, we have our data. The variability between the pentacams is not too bad. We're at 0.11, which is remarkable. We're probably going to take out this guy, which already has a question mark. It's the least accurate of the bunch. And this leaves our average still at 0.11. And maybe, George, you want to pick an outlier?
Well, I think this one that you picked is an outlier. And the next one that's similar to that is
Number 2 again.
number 1.
Okay. Let's try number 1. Try number 1.
But again, if you look at these two color pictures, you would say, well, they're very different.
Right.
But by the numbers, they're both the outliers.
Right.
So it's very difficult to use color pictures to tell.
Yeah, let's take out number 1 too. And now 4. Okay, so now our average gets worse actually. So that's, again, it's a little bit of a trial and error thing. Let's put back number 1, take number 2 maybe. So this is probably the best medium that we have now. We go to 0.05 deviation with just taking out number 2. All right. So let's go to the next step and let's try and see how we would treat this inferior flattening now. Okay. So we have the numbers in. Okay. We'll do this patient first. Well, this will be very fast. So let's make it a flat 0. Results with 5.5. Okay. We'll have Dr. Waring decide on the direction. Put perfection 0 so we can see what. So this is basically what the laser will try to do on this pentacam. Normalize it. So it's the exact opposite of the astigmatism. It's going to try and take down the sleep area here, and then in order to make the significant flattening from the scar normal, it's going to do a hyperopic treatment away from it to make this area come up. So it's a two-step approach. Again, we're going to try and look at the placebo disc image here and make sure this makes sense. We can already see that the axis is a little bit off. This is the axis by pentacam where the placebo is a little bit more vertical. So we'll see that when we compare the two. Now, as far as the refraction,
And just to state a basic principle here, an excimer laser cannot steepen the cornea.
exactly.
So in order to make it relatively steeper, then we have to go out and flatten. And that's the same thing as if we were treating +2. You would flatten the paracentral area to make a relatively steeper center.
Exactly.
So this is the same idea. Try to take care of this flat spot from the scar.
Exactly. Good. So the device gives us 4 diopters of astigmatism. We measured 165. We probably wouldn't do more than what it measured, maybe 225. Okay. And let's do from the 1 diopter. Let's put it on. So this is probably what we do as a treatment. Okay? Oh,
And in any case, this is where Dr. Kanellopoulos' experience comes in, because if you look at this cornea, it's multifocal everywhere. So we're trying to create astigmatism correction, which is very different up here than down here. We're trying to create a spherical correction, which of course is very different up here than down there. So there's a lot of intuition and experience in designing this kind of a treatment that you can't just read off the screen.
Let's save this and let's see the placebo test. Because this is a very interesting case where the two will not compare, and because of the opacity, we'll probably going to choose the placebo test image instead of the handicap. So I think just by luck today, we covered pretty much the whole spectrum of topogaia. Where do we expect more of the placebo disc image, where more of the pentacam? Alright, so we have just two good topographers for the reason that Dr. Waring mentioned. A lot of them had eyelids in them. So the device already has done most of the job for us. It tells us these two are the topographies that are good enough to be used.
And just a point for the technical side, the person that's taking these pictures usually is one of our technical staff who need to be trained to say, well, wait a minute, I have a lot of pictures with the lid in the way. So maybe it's time to tape the lid up, hold the lid up, help the patient get the lid out of the way. Sometimes these patients will have like a seventh nerve palsy or something else. So,
This is even with lids up. Sometimes you put a little Q-tip in there and try and roll it up.
Yeah, so you have to do the best you can. This may be the best you can.
Alright, so let's see how this turns out. Yeah. So now we're seeing things a little bit different here. Alright, so what we're seeing here is that this is trying to treat more with the rule, which corresponds with our placebo disc images more. The pentacam is a little bit more oblique. So that automatically for me scores a few points towards choosing this. And let's try the same refraction. We said -1, -220. And now the other interesting thing is that the astigmatism that the device wants to treat here is just 1 diopter and 1.11, where the pentacam wanted to treat 4 diopters. So again, this is a game of not treating 2 diopters of myopia and a young myope. This is trying to figure out which treatment would better normalize this topography. So we're going to try and stay with the same numbers and see how that treatment plan will look like. Alright, good. So our case have to be set up in there. So now here we're seeing the difference between the topalizer and the pentacam. The confusing thing is that I still like very much the fact that the pentacam is trying to normalize this. So I'm going to break rank here. I'm going to use the pentacam because I think the problem here is the extreme flattening that this cornea has down here, where I don't think it's addressed enough by the placebo disc image. So we're going to go pentacam.
It's called experience. Russell, would you go back on screen, please? Sure.
Which one?
There's a button. I want to make the point that there is a transition zone in these, and you really have.
Let's try this one.
Good.
Oh, here it is. So now I thought that was 5.5. You said 5.5.
Yeah.
Right.
Changes.
So we can also change the transition mode.
But this is important in terms of reshaping the cornea. If you say an optic is only 5.5, you would say, well, that's not very far out. But now we've got another 1.25 for the transition zone. So now we're trying to help make the cornea more prolate by dealing with which is actually the paracentral cornea in addition to the central.
Okay, so we can see here just the difference between the hyperopic correction, which is 56 microns in depth, and the paracentral cornea, which is maximum about 20 microns. So this difference, 30 so microns, is about 3 diopters of correction alone. So this will induce a little bit of myopia centrally. So I think we've addressed the myopia a little bit. We may, we're going to use the Pentacam because although the axis may not be fully on, let's use the Pentacam with the placebo axis. Let's do that. So let's see if we can adjust the axis here. It's the same. Let's do 20. The placebo axis was 20. Let's see again. Let's see. Let's go forward. Yeah.
John, would you please say something in general for the listeners about customized treatments? I mean, we're a long way now from treating -3 with an excimer laser. Say something about that advance.
Well, the device has the potential to do a lot of good, but it has the potential to do a lot of wrong as well. Because the device only reads topographies, and as we saw before, we have to be certain that the topographies correspond with the actual clinical picture. And then again, these are such dramatic changes within the cornea that they may hold a refractive surprise. We think we're treating a refractive error here, but I wouldn't be surprised if this case ended up being a +1.5 or a -1.5, which would be considered in normal refractive surgery a disaster. But the key thing here is that we're trying to improve best spectacle corrected visual acuity. So I would take a +1.5 outlier if that gave that patient 3-4 lines better vision. And also gives you the window of coming later either with lens-based surgery or with laser surgery correcting the spherical residual if there is such.
And this is one of the things that I've learned in studying with Dr. Kanellopoulos is that the actual outcome is what the patient sees. We know that, but we're dealing with topographies here that don't really tell us what the patient's vision is.
Good. So we'll get started right away.